Hello guys, today we'll be talking about a case which we have done in our hospital recently. It's a case of PCA to RCA. So we're doing a case discussion on that. So it was a 60-year-old female patient with no medical comorbidities. She came with complaints of chest pain since last 4 hours. So what we do immediately, so when the patient presented, we took an immediately ECG was taken. You can see here this ECG, it was a 12 lead standard ECG. So before going to any ECG, first you should know the what is the standard ECG, read every time. So go from the basics all the time. So normal speed of the ECG should be 20 millimeters per second. For to label it as standard ECG, the speed of the paper is 25 millimeters per second. Along with that, 1 millivolt is equal to 10 millimeters. So that means each small square is 0.1 millivolt, that is 1 millimeters. So you have to check that. So here it's not mentioned, but I have checked that before interpreting this ECG. Then you can see that patient have a sinus rhythm. As you can see, there is a P followed by QRS and then a T wave. So every QRS is preceded by P wave. So it is a sinus rhythm. It's regular. So no arrhythmias or anything. So it's a regular rhythm. And then coming to, you can see here, there's a classical ST segment elevations in the lead 3, lead 2, and AVF. So lead 2, lead 3, and AVF denotes what is known as inferior wall MI. So in any inferior wall MI, what are the additional features, additional information which you can gather from the ECGs? That on also important thing is that along with the ST elevation, you can see a reciprocal changes in the lead one AVL. You can see there is ST segment depressions was there in the lead one AVL, which is also highly feature suggestive of that it is a STEMI. It is not other cause of ST elevations. It's basically MI. To label any patient as myocardial ischemia, you should have a reciprocal changes. That means reverse changes should be there, which is seen in the lead AVL and lead 1. Also, you can see some ST segment depression and prominent T wave in lead V2. So supposing any ECG patient have a ECG of this type, you should always suspect that there could be a posterior wall MI as well. So because we do not take posterior wall leads, the patient may be having a posterior wall MI. That's why in anterior leads you have a reciprocal changes, and very commonly inferior wall MI is associated with posterior wall MI. So can we say based on this that whether inferior wall MI is associated with right ventricular MI or not? So the answer is here is no, because usually if inferior wall MI is associated with right ventricular MI, there will be some subtle V1 elevations will be there. You are here saying is V1 is depressed. V1, there should be elevation in the V1, which should be more than V2 along with the lead 2, 3 AVF. So remember as a routine that for any patients of inferior lemma, always take a posterior leads ECG as well as the right-sided leads, that is called as V4R. So this patient was immediately taken for angiogram, and angiogram is shown below. So here you can see here that patient have so I'll play the video here. You can see this patient has acute occlusion of the right coronary artery. So what we took was for the support of that, we took a guide. This is called as guide liner because this was a JR guide which was not getting hooked. So we took that thing and so this was RCA occlusion and we took JR guide. This was the guide liner. The wire was crossed. Now we are opening it with the balloon. You can see here the balloon has been taken, which is a non-compliant balloon. We are trying to open it. But after doing the balloon also, the lesion was still tight and all. So that's why we have to take a scoring balloon, which we took. So after doing a scoring balloon and also we needed a support of, this is called as guide liner. You can see here. So after doing the with the scoring balloon, that is the lesion. You can see this is the scoring balloon which we are doing here. The lesion has opened quite well, which you will see in this shot. You can see the lesion has very much opened. Then the stent was taken. So we took a size of stent of around 3.5 into 38 millimeters, and the stent was deployed. Now we are doing the post dilatation, which you can see here, and the final result you can see here. So, so that was a very good result which we got. So important thing to remember is that during this procedure, we used accesses the right radial artery. 6F sheath was taken and the guide wire used was run through. So first, the guide which we took was JR guide. So JR guides is looks like this. You can see here JR 6 French, 5 French, 4.54, 3.53. So JR guide was taken for because JR are usually very well for the right coronary arteries. But important thing was that in during this procedure we were not having much support when the guide that RCA was engaged. So we took support of something called as guide liner, which is inserted into the uh, guide. So basically the sixth French guide, we inserted guide liner just to support further. And then the material, that wire and everything was crossed from this guide liner, and also the stent was deployed. So you can see again here we have taken the support of guide liner, which you can see here, the small portion which you can see here, a bulb-like thing which is there. This is the guide liner here. So after guide liner, the wire was crossed. The wire used was run through, which is a hydrophobic wire. That means it is not very stiff and very much less chances of perforation in this patient. So after doing that, we take the balloon, and most commonly we do pre-dilatation with the NC balloon. That is non-compliant balloon was taken. So lesion was tried to open, but it was not opening quite well. Then we have to took a scoring balloon. Scoring balloon is nothing but this had these are the balloons which contains the wires. So you can see here the wires. You can see here these are the wire on the balloon. Normally the wires are not present. So this is used to cut the calcified vessel. So this patient has a very calcified artery. So we break that calcium. We use the scoring balloon. After using the scoring balloon, the lesion opened quite well, and we got a very good result. So let's go through the video one more time so that you understand all the steps. So this was the occluded artery. Now the guideliner was taken for support. The wire was crossed. We are doing is the balloon, that is pre-dilatation. We are doing here. So you can see the lesion opened. The balloon size was initially of 2 into 8 millimeters. Later on, we took, because the lesion was not opening well, we took what you can see the lesion was still tight here. So what we took the scoring balloon as we discussed, and after that the lesion opened quite well. And finally we have taken a stent of size 3.5 into 38 millimeters, which was implanted here. You can see this is a stent here. So finally the result was very good, and patient was satisfied and asymptomatic, and she is being discharged today. So this is our final result. Thank you.